of vancomycin utilizing AUC to MIC, which was a 2020 update from clinical practice guidelines by the Infectious Diseases Society of America and the American Society of Health System Pharmacists and the American Society of Infectious Disease Pharmacists. Before we begin, I'd like to say that I have no financial or other disclosures that would impact the integrity of this presentation. By the end of this presentation, you all should be able to describe clinical and pharmacokinetic properties of vancomycin, compare and contrast trough-based versus AUC to MIC monitoring for safety and efficacy, discuss specific dosing considerations in our patient population, and implement AUC and MIC monitoring in your practice at Erlanger. So I'll begin with a brief overview of vancomycin, which I'm sure we're all familiar with this drug, but it's a glycopeptide antibiotic, meaning that it inhibits cell wall synthesis by binding D-ala-D structure of peptidoglycan to prevent transpeptidase from cross-linking the peptidoglycan layer. So basically it leads to osmotic cytolysis, and that's how it exhibits its bactericidal activity. Clinically, it's used for empiric or definitive MRSA coverage or in patients who have a penicillin allergy. The main adverse effects of vancomycin are nephrotoxicity and red man syndrome. Vancomycin is administered IV or orally for treating C. diff. Distribution is 30 minutes to about an hour for absorption, and the half-life is 6 to 12 hours in patients with normal renal function. It has a moderate volume of distribution and low to moderate protein binding and penetrates the CSF better in the presence of inflammation. Vancomycin is almost completely renally eliminated, with 80–90% being excreted unchanged in the urine. So I'll begin this presentation with a question for you all. What parameter best predicts the efficacy of vancomycin therapy? A, duration of therapy, B, time above the MIC, C, AUC to MIC ratio, or D, the peak concentration of vancomycin? C, yay! Good job, everybody. Okay, and here I have a graphical image for you all. I apologize, I did not define MIC, so for those of you who are not familiar, MIC is the minimum inhibitory concentration, and for most of America, the MIC of vancomycin is 1 for MRSA. So I'd like you to keep that in the back of your mind throughout this presentation. So as we can see here, this MIC, or minimum inhibitory concentration, is our value. It's the minimum concentration of vancomycin we need to inhibit bacterial growth of MRSA, and as I mentioned, that would be 1. Here we have our Cmax, or a max concentration, and this area right here is what we want to optimize when dosing vancomycin. So it's taking into consideration the concentration above the MIC and the time it's at that adequate concentration. So we do this by utilizing pharmacokinetic equations to optimize therapy, which I will go into a little bit later in the presentation. So here I have a pharmacokinetic and pharmacodynamic graph by Ryback and colleagues that shows the relationship between change in log of colony-forming units of MSSA on the left-hand side, and then different pharmacokinetic and pharmacodynamic indices on the x-axis here. So on the your left, we have the x-axis depicting 24-hour AUC to MIC, and as you can see, there's almost a direct linear correlation with decrease in colony-forming units of MSSA with increasing AUC to MIC. So let's see if I can depict this a little more easily. So here we have high colony-forming units. The higher your AUC to MIC gets, the less colony-forming units you have. So this is showing your bactericidal efficacy as an increase, or a function of an increase in AUC to MIC. In the center portion of this graph, we have the peak concentration over the MIC. As you can see, there's not a great correlation between increase in peak concentration and bactericidal efficacy against MSSA, and that's depicted. You don't see really any kind of linear trend here. And if we move to the far right, you have time above MIC. So harking back to that graph, it's the amount of time you are above that MIC level. There's no correlation in time over MIC with vancomycin's bactericidal efficacy. So now I'd like to go over the current guidelines we are all probably most familiar with in practice, which is the 2011 IDSA guidelines for the treatment of MRSA infection. So as we all know, vancomycin dosing is recommended to be 15 to 20 mg per kilo per dose every 8 to 12 hours using actual body weight in patients who have normal renal function. Loading doses of 20 to 30 mg per kilo can be considered for seriously ill patients. That is not clearly defined in the guidelines what seriously ill is, but we normally think of that as patients with MRSA, so sepsis, meningitis, pneumonia, endocarditis. The 2011 guidelines recommended drawing a trough at steady state, so prior to the 4th or 5th dose, and this recommendation was based on the fact that this was going to achieve an AUC to MIC greater than 400, which we know is the best clinical predictor for efficacy against MRSA. And to target that, trough goals were 15 to 20. And just as an aside, for non-severe skin and soft tissue infections, trough monitoring is not recommended. So now I'd like to go into a little bit about the 2011 guidelines and why they were updated. So first we'll touch on what is trough-based monitoring efficacious, and then I'll move into talking about nephrotoxicity associated with trough-based monitoring. So here I have a graph for you. It's got concentration, or vancomycin trough concentration on the x-axis and AUC on the y-axis. So this was a pharmacokinetic model that was conducted to show different trough correlations with AUC correlations using dosing of 1 gram every 8 hours. This model was based off of patients of varying sizes and renal function. So basically, I'd like to orient you to this box right here, which depicts a trough of 15 to 20. And this is where the 2011 guidelines get their recommendation of 15 to 20, because as you can see here, all of the AUCs that correlate with a trough of 15 to 20 are pretty much guaranteed to be greater than 400, which we know that is our predictor of efficacy of vancomycin therapy. And there I have lined out for you here. That is approximating an AUC of 400, and we can see when we're in that range of 15 to 20, we're pretty much guaranteed that 400 AUC. Something else I'd like to point out about this graph is if you look to your left, even low troughs, less than 10, even less than 5, can still achieve an AUC of greater than 400. So there's a wide distribution of troughs that are associated with what we would consider a therapeutic AUC, which is why the new guidelines are favoring AUC to MIC monitoring. So now I'll talk a little bit about the data associated with trough-based monitoring. Here I have a meta-analysis by Tongsai and colleagues that looked at various endpoints regarding high and low trough vancomycin-based dosing. The trough cut points for the high trough was greater than 15 and less than 15 for the low trough cut points. Patients included in these studies had a variety of MRSA infections, including sepsis, endocarditis, bacteremia, and pneumonia. Most of them were floor patients, with one study including critically ill patients. And so what they found was regarding clinical efficacy, there was no statistically significant difference in the pooled odds ratio regarding high trough over 15 compared to low trough less than 15. And the pooled odds ratio for the studies was 1.07 regarding clinical success. And then in this study, clinical success was not completely consistently defined across trials, but all trials included 30-day mortality, bacteremia greater than 7 days, and improvement of symptoms depending on the infection that they were treating. This meta-analysis also looked at mortality regarding high or comparing high to low trough-based dosing. Again, high trough greater than 15, low trough less than 15. Mortality across all studies was defined as within 30 days all-cause mortality, and they did not find a statistically significant difference when comparing high trough to low trough in the pooled odds ratio of 1.09. One of the strengths of this study is that the investigators took out each individual study and repeated the analysis and still found no difference between high and low trough regarding mortality, clinical success, or nephrotoxicity, which I'll talk about a little bit later, meaning that no one study was really impacting these results in one direction or the other. The next study I'll talk about is conducted by Culler and colleagues. It was a retrospective analysis of vancomycin treatment failure, which was defined as persistent bacteremia greater than 7 days in patients with MRSA bacteremia. This trial stratified trough goals by less than 10, 10 to 15, 15 to 20, and greater than 20. And as we can see here, the trough goal that was associated with the lowest amount of vancomycin failure was the trough of 15 to 20, and that was still associated with a 40% rate of treatment failure. Troughs less than 10 were associated with the highest risk of vancomycin failure, and troughs greater than 20 were associated with a 50% risk of vancomycin failure. This study also found that troughs greater than 20 were associated with the highest risk of nephrotoxicity, as we would expect. So to kind of summarize what I just talked about, trough-based dosing, which was found in a few meta-analyses, is not necessarily more efficacious when you're targeting these trough goals of 15 to 20. And now I'll move into talking about, is it more nephrotoxic? So some established risks for nephrotoxicity with vancomycin therapy are a daily dose greater than 4 grams, troughs greater than 15, duration of greater than 7 days, use of concomitant nephrotoxins such as piperacillin and tazobactam, NSAIDs, and ACE inhibitors, pre-existing renal disease, dehydration, obesity, and critical illness. So a systematic literature review by Van Hal and colleagues analyzed 4 studies that provided nephrotoxicity rates as a function of trough intervals. So again, we have that breakdown of troughs less than 10, troughs of 10 to 15, troughs of 15 to 20, and troughs of greater than 20. The various infections in these studies included range from MRSA bacteremia, pneumonia, and bloodstream, I already said bacteremia, and meningitis. As we can see, troughs greater than 20 were associated with the highest percentage of nephrotoxicity risk at greater than 30%, and troughs less than 10 were associated with the lowest risk of nephrotoxicity, less than 15%. The definition of nephrotoxicity is consistent across all studies, and that was defined as an increase in serum creatinine of 0.5 or 50%, which is a commonly established definition of vancomycin-induced nephrotoxicity. So next I have the same meta-analysis that I just previously described, and they again compared high troughs of greater than 15 to low troughs of less than 15 regarding nephrotoxicity, and found a pooled odds ratio of 2.67 for increased risk of nephrotoxicity associated with a high trough group of greater than 15. Some risk factors for nephrotoxicity are vancomycin greater than 4 grams per day, weight greater than 101.4 kilos, and creatinine clearance of less than 86.6, and this was found by a retrospective cohort study by Lodiz and colleagues that compared vancomycin high dose greater than 4 grams a day with vancomycin low dose less than 4 grams a day and linezolid. And then these endpoints were found in a post hoc analysis to be statistically significant and like the highest risk of hazard ratio associated with increased risk of nephrotoxicity. And then here's a graphical representation of what they found in their study when comparing linezolid, low-dose vancomycin, and high-dose vancomycin at greater than 4 grams a day. So as you can see, the dotted line on the bottom is our vancomycin high dose greater than 4 grams a day. And at about 5 days of therapy, you start to see a pretty big drop in the percent of patients who remain non-nephrotoxic. Apologize, I forgot to orient you to the axes. On the x-axis, we have days after initiation of therapy, and on the y-axis, we have the probability of remaining non-nephrotoxic. So the lower you're going in the graph, the higher risk of the higher incidence of nephrotoxicity is occurring. So our doses of greater than 4 grams per day at about 5 days start to show a pretty large divergence from doses of less than 4 grams per day. And you can see the investigators actually found at about day 7 of therapy, that's when you really start to see an increased risk of nephrotoxicity when comparing to a non-nephrotoxic agent like linezolid. And I have that highlighted there, that the divergence really starts to occur at day 5 of therapy. And then day 7 of therapy, you get another large drop, particularly when using high-dose vancomycin. So going back to the previous meta-analysis by Tongzai and colleagues, they also analyzed nephrotoxicity as part of their endpoints. This was defined uniformly across studies as an increase in serum creatinine of greater than 0.5 or 50%. And again, comparing high trough versus low trough endpoints, with the high trough being greater than 15 and the low trough being less than 15. They found there was a pooled odds ratio of 2.14 with higher risk of nephrotoxicity in the high trough group. So to summarize what I've just discussed on nephrotoxicity, Van Hal and colleagues found that nephrotoxicity at troughs greater than 15 was significantly increased when comparing to troughs of less than 15. And they concluded that the risk of nephrotoxicity was significantly increased after 7 days of therapy. Tongzai and colleagues also echoed that same sentiment, that troughs of greater than 15 led to increased risk of nephrotoxicity when compared to troughs less than 15. And Lodiz and colleagues, when comparing high-dose vancomycin to low-dose linezolid, found that doses greater than 4 grams a day and a treatment longer than 7 days were risk factors for the development of nephrotoxicity. So trough-based monitoring, not necessarily more efficacious and higher risk of nephrotoxicity, which brings me to the 2020 Clinical Practice Guidelines update that recommend AUC to MIC monitoring for MRSA bacteremia. So the new guidelines recommend to target a AUC to MIC of 400 to 600 when treating MRSA bacteremia. Dosing recommendations are really similar to the old dosing, with a loading dose of 20 to 35 mg per kilo based on actual body weight, and you can consider this in serious infections, and then followed by a maintenance dose of 15 to 20 mg per kilo based on actual body weight every 8 to 12 hours. So while the dosing is remaining consistent with the new guideline update, the big change is how we're monitoring therapy. So to discuss the efficacy of AUC-MIC dosing, Moyes, Broader, and colleagues investigated if AUC-MIC values were correlated with increased treatment efficacy. 108 patients with Staph aureus lower respiratory tract infections were treated with vancomycin for at least 3 days of therapy and then analyzed in this retrospective study. Investigators found that vancomycin AUCs, MICs greater than 350 were associated with improved treatment success with an odds ratio of 7.19 compared to AUC-MIC less than 350. And if we look to the left or to the right, this graph here compares AUC-MIC greater than or less than 400 from the same study. On the x-axis we have days of treatment, and then on the y-axis we have percentage of cultures positive. So as you can see, the heavier line on the bottom depicts AUC-MIC greater than or equal to 400. And the percentage of culture positive significantly declines as treatment continues. Of note, they only took cultures every 3 days, so the graph might show like a more linear trend if they were to do daily cultures. And then AUC-MIC of less than 400 kind of tapers off at about 80% or 20% success at culture eradication. So now I'd like to orient you to an association between AUC-MICs of 400 and actual real-world troughs. So here we have a graph that was adapted from Neely and colleagues. They took a pharmacokinetic model and computed that using 2 different dosing regimens of 1 gram every 12 hours and 1.5 gram every 12 hours. So I'd like to orient you to the x-axis, which depicts vancomycin trough concentrations, and then the y-axis is the density of populations that achieved an AUC to MIC of 400 at a set trough value. So basically they had some known patients who were very well followed and studied and had a lot of therapeutic drug monitoring done, and they plugged all of that data into a pharmacokinetic model and were able to generate this graph. And so what you're seeing here is that the majority of patients achieved an AUC to MIC of 400 with a trough of 10. And then there's a wide range of troughs that correlate with an AUC to MIC of 400. So this peak is basically representing the amount of patients in the pharmacokinetic study that achieved an AUC MIC at a particular trough. So what I'd like you to take from this is that our previous trough goals of 15 to 20 are not really necessary to achieve an AUC MIC of 400 and might actually be detrimental because we're causing an increased risk of nephrotoxicity. Again, another study by Patel and colleagues took another pharmacokinetic model and used different dosing variations in patients with different renal functions, and then compared their AUC, their predicted AUC MIC with their predicted troughs. So as you can see here, using a 1 gram every 12-hour dosing regimen, you can get a therapeutic AUC MIC in patients who have a renal function with a creatinine clearance of less than 80 mils per minute at 3 to 4 days. So you can see here, using this dosing regimen with a patient with relatively good renal function at 80 mils a minute, you get an AUC of 474, and then the trough that correlates with that is 9.7. So again, therapeutic AUC to MIC with a trough much less than what we would normally target. And then as your doses increase, your probability of achieving an AUC to MIC of greater than 400 significantly increases. And then same thing with renal function. As your patient's renal function decreases, your probability of adequately getting an AUC MIC greater than 400 with a trough of less than 15 increases as well. So to kind of summarize what I just discussed, troughs are not necessarily the most accurate marker to measure AUC to MIC, and a variety of troughs can account for a therapeutic AUC to MIC. So a lot of what we're doing now with trough-based monitoring and targeting troughs of 15 to 20, again, can be overdosing our patients or achieving an AUC MIC outside of that range of 400 to 600, which is what the new guidelines recommend. So now I'd like to discuss the PROVIDE trial. This was a prospective observational multi-center study conducted to evaluate AUC to MIC exposure regarding treatment failure for MRSA bloodstream infections. Treatment failure was defined as presence of bacteremia after 5 days of being on vancomycin therapy. The cutoffs for this study when assessing AUC to MIC were greater than or less than 650 and then greater than or less than 320. And this is a little bit different than what the guidelines recommend. That's because in a previous study, the authors, Lodiz and colleagues, found these to be statistically significant endpoints for treatment success in a study they did back in 2014. So they chose these to proceed forward. And what they found is that there was no statistically significant difference in treatment failure when targeting an AUC MIC of greater than or less than 650. And again, no difference in persistent bacteremia, 30-day mortality, acute kidney injury, which was defined as an increase in serum creatinine of 0.3 or 50%, and then vancomycin-induced nephrotoxicity, which I mentioned the definition for that, again, was an increase of serum creatinine of 0.5 or 50% increase after being on vancomycin for 48 hours. And again, in their group of greater than or less than 320, they did not find a statistically significant difference between treatment failure, persistent bacteremia, 30-day mortality. But they did, however, find a statistically significant increased risk of AKI and VINT, or vancomycin-induced nephrotoxicity, when targeting AUC to MIC greater than 320. So to conclude these findings, higher AUC MIC was not necessarily associated with treatment success. And then acute kidney injury and vancomycin-induced nephrotoxicity rates were higher in the AUC MIC groups greater than 320. So what I want you to take from this is that targeting high troughs and high AUC MICs doesn't necessarily get you better outcomes with your patients, and it does get you higher risk of nephrotoxicity. So it's not necessary to be targeting troughs on the high end of 600 consistently. It's better to just go within even the lower end of guideline recommendations, closer to that 400 if possible. And the investigators of the PROVIDE study actually concluded that a day 2 AUC MIC of less than 515 was the ideal way to maximize therapeutic efficacy while minimizing nephrotoxicity with their patients. And they found this through a post-hoc DOR analysis that they referenced in their study. So the next study I would like to discuss is by Finch and colleagues. They studied at Detroit Medical Center the transition from trough-based monitoring to AUC MIC-based monitoring, and then compared the patients who remained non-toxic or non-nephrotoxic between the two groups. So as you can see here, our dotted line is trough monitoring, and our solid line is the AUC MIC monitoring. So all patients had MRSA infections of variety, including bacteremia and pneumonia. So we can see here that using trough-based monitoring actually led to a lower proportion of patients who are non-toxic or a higher proportion of patients who became nephrotoxic compared to AUC-MIC monitoring. So what this is showing is that AUC-MIC monitoring is actually associated with less nephrotoxicity when compared to trough-based vancomycin monitoring. And again, from this same study, the investigators used Bayesian software to estimate vancomycin exposure profiles and then compared that between groups, so the trough-based monitoring and the AUC-guided dosing group. So what we can see here is that trough-guided dosing group led to higher troughs when compared to AUC-guided dosing group. So we can see at 24 hours in the trough-guided dosing group, the median trough was 12.7 compared to 10 in the AUC-guided dosing group. And then at 48 hours, it was 14.2 compared to 12.5 in the AUC-guided dosing group. And same thing with AUCs. They were higher in the trough dosing group compared to the AUC-guided dosing group, with an AUC at 24 hours of 474 in the AUC-guided dosing group and 705, which is outside the guideline recommended range in the trough-guided dosing group. So again, just to reiterate, what I want you to take from this study is that trough-based dosing is associated with higher troughs, higher AUCs, which are both associated with higher risk of nephrotoxicity. Which is kind of stated here for you. So to kind of conclude all of that data, the goal of AUC-MIC monitoring is really safety. We're trying to prevent those toxic levels while achieving some therapeutic efficacy, but as we found in the PROVIDE trial, higher AUC-MICs are not necessarily more efficacious. So really we're just trying to optimize therapeutic efficacy, but really focused on minimizing nephrotoxicity by using AUC to MIC. So now I'd like to talk a little bit about how we can implement this in our practice here. So first I'll go over how you calculate AUC to MIC. There are two ways. The first is that it's guideline recommended is using Bayesian software, and then the second is using first-order pharmacokinetic equations, which is what we'll be doing here at Erlanger. So the Bayesian-derived AUC monitoring software is basically a pharmacokinetic probability software. It's a statistical model that you impute patient data to, and it predicts what your AUC will be after putting data in. So you could put a trough concentration, you could put a peak and trough concentration, and then this model will predict what your therapeutic AUC will be. The pros of this model are that you only need one level to impute for it to actually calculate a proposed therapeutic AUC, and it's adaptive. So the more data you put into this program, the better it learns and the better it gets at predicting accurate AUC to MIC ratios. One thing I will say about this is while you only need one concentration to calculate an AUC-MIC with the Bayesian-derived software, you get better, more accurate data if you do put in a peak and a trough. And then same thing with steady state. You don't technically have to wait till you're at steady state. You could draw an AUC at any point in therapy, or sorry, a trough or a random level at any point in therapy, but you get better data if you wait until the patient's at steady state. So the cons, the main thing is that this is a subscription service by many different companies that create this software, so we don't have it here at Erlanger. But other than that, it's really used a lot in research, and then the PROVIDE study used it as well to calculate AUC to MIC. So what we use at Erlanger is first-order pharmacokinetic analytical equations. And before I freak anybody out, you won't actually have to get out your pen and paper and do calculus. We do have an Excel document here that you can plug things into, and it will generate values for you. So kind of a throwback to calculus, you estimate an AUC using a peak and trough concentration at steady state. This kind of modeling, unlike the Bayesian software, provides a snapshot of your AUC to MIC during a sampling period. So the Bayesian software is actually predictive and will kind of follow the patient throughout the course of therapy as you continually input values, whereas this is only going to tell you what the AUC-MIC is for that sampling period that you calculated or that you drew your peak and your trough. The biggest limitation to this kind of model is education of nursing staff. So I think Summer could probably speak to this a little bit more, but our nursing staff is really used to drawing trough levels. So you have to provide some pointed education on how to draw a peak and a trough and do that properly. The other thing that's kind of a con to this modeling is cost of laboratory monitoring. So you have to get 2 levels instead of 1, so we're effectively doubling our vancomycin lab monitoring costs when using this. So now I'd like to take a little break from talking and let you guys think for a second. So we'll stop with a concept check. A 98-kilogram male presents with severe cellulitis caused by strep pyogenes. Can anyone tell me what the goal AUC to MIC ratio would be for this patient? Yes, it's a trick question. All right, thanks, Kyle. Yeah, so the guidelines recommend the AUC MIC target of 400 to 600 only for MRSA, and it was really primarily studied in MRSA bacteremia. So we're not really applying this to a broad spectrum of organisms. So when you get something back, your first question should be, well, should we be using Vanc? Is this the most appropriate drug? And then the second question would be, well, I don't really have an adequate AUC MIC target. And you could maybe do some primary literature and try to find one. But I think the first question would be, don't use vancomycin in this patient. And yeah, I really just bring this to your attention to point out that this cannot be applied to all organisms. This is really just specific for MRSA. So now I'd like to discuss just the real-world application of this AUC MIC monitoring. So most vancomycin use is for empiric coverage with a duration of less than 3 days in the hospital stay. So it's not really necessary to optimize empiric coverage by drawing peaks and troughs to establish an AUC MIC of 400 to 600 in short treatment durations. This would actually be kind of a waste of resources if our plan is to discontinue vancomycin once cultures come back. And also, an aside, as I mentioned earlier, AUC to MIC is really primarily focused on safety. We don't want to be overdosing our patients and getting really high troughs. And most nephrotoxicity occurs after 5 to 7 days of therapy or with large doses. So as long as you're on treatment therapy for less than 5 days, it's not really necessary to be drawing a lot of levels in these patients. And then another point is with early days of hospital stay, renal function fluctuates pretty often, which affects vancomycin accumulation and clearance, which will also affect your AUC to MIC. So it's really difficult to accurately estimate an AUC MIC within the first 48 hours of a hospital stay. So it's not really prudent to be applying this to your empiric coverage. So I did a medication use evaluation of vancomycin at Erlanger. So I looked at 100 patients who pharmacy was consulted to dose vancomycin from August 1st to September 15th. And the results I found were that 31% of consults resulted in discontinuation of vancomycin after the first dose. This then resulted in an average duration of 1.81 days of vancomycin therapy. And that isn't including patients who were consulted by infectious diseases. So that would include patients who were on vancomycin for osteomyelitis, endocarditis, disease states that have long treatment duration. So this kind of skewed my average treatment duration day. So I excluded patients who had an ID consult and found that the average duration of vancomycin was 1.04 days before empiric coverage was discontinued. And then of those 100 patients, only 15% of them actually had confirmed MRSA culture data documented in their chart, and then 19% of them had resulted in an infectious disease consult. So basically what I want you to get from this is that we don't need to be doing a lot of therapeutic drug monitoring on these patients because most patients are going to be on vancomycin for less than 48 hours before it will be discontinued. So keep that in mind. And this is really just reserved for patients who we know we're going to be on vancomycin for a while. We know this is the definitive drug of choice for this patient. And before we hop into a case, I'd like to talk a little bit about loading doses. So this was another pharmacokinetic model that used a 70-kilogram patient and calculated AUC doses based on a dosing regimen of 20 mg per kilo load or a 25 mg per kilo load. And they found that when using a dose of 20 mg per kilo loading dose, even in patients with really good renal function, this loading dose provided adequate AUC to MIC of greater than 400, as you can see here. And then again, with the higher end loading dose of 25 mg per kilo, this provided adequate AUC MIC coverage, if not even too high of AUC MIC coverage for these patients. So if you're using a loading dose, you're pretty much guaranteed to get a therapeutic AUC to MIC ratio within that first time period. So for those of you who may be kind of nervous about not doing therapeutic drug monitoring to achieve that optimal AUC MIC of 400, this really shows that loading doses do help us achieve that early on in therapy, which we know is a good predictor of patient outcomes. Another thing I will say, I know this is a 70 kilogram patient, and a lot of patients we see at Erlanger are not 70 kilograms and may be obese. We'll talk a little bit about that during our case that I'll walk you guys through, but we do prefer doing therapeutic drug monitoring in patients who have risk factors for nephrotoxicity, such as our obese patients. So to kind of summarize what I just talked about, there's no need to monitor AUC MIC for empiric vancomycin. Loading doses almost always ensure adequate AUC to MIC exposure over the first 24 hours. And again, there's no need to monitor AUC MIC for short treatment duration, so skin and soft tissue infections, where we're treating for less than 5 days. As I mentioned, your highest risk of nephrotoxicity occurs after day 5 of therapy, and we're doing these monitorings to make sure that we're not putting the patient at high risk of nephrotoxicity. And then I'd like everyone to think about, if vancomycin is selected as definitive therapy, is it the best therapy for this patient? So factors to consider would be drug distribution and predisposition to AKI. So patients with obesity, CKD, diabetes, fluctuating renal function, and critical illness may not be great candidates for vancomycin. And if you are choosing to use vancomycin in these patients, it's probably worth doing some therapeutic drug monitoring. And in this instance, I will say getting trough levels on these patients would be perfectly reasonable if you're checking for safety. You want to make sure you're not getting a trough of 20 or even necessarily 18 in a lot of these patients, because you're putting them at risk for acute kidney injury. So now I'd like to walk through a case with all of you. So here we have a 43-year-old female who is diagnosed with endocarditis. She's started on empiric therapy with vancomycin. She has an actual body weight of 100 kilograms and an ideal body weight of 60 kilograms. Her creatinine clearance is 70 mils per minute. So what dose would you like to give her? And I won't make anyone do math. You can just tell me like 10 mg per kilo or whatever you think. Sure, okay, that sounds great. 1.5 Q12, so would you want to give her a loading dose? Yeah, great, okay. So we can do a loading dose of 2 grams and then followed by 1.5 Q12. And when would you like to draw therapeutic drug monitoring in this patient, or would you like to draw therapeutic drug monitoring in this patient? Great, yeah. I think that's perfectly reasonable. We can do AUC to MIC monitoring if we get an organism back and it's confirmed MRSA. Another thing to consider in this patient, she is obese. Her renal function isn't stellar. It's not terrible, but it would be appropriate to get a trough after a few doses once she's at steady state, just to make sure you're not overdosing her or putting her at increased risk of nephrotoxicity. So our culture and sensitivities come back, and we have MRSA. What is the AUC MIC goal for this patient? Awesome. Yes, 400 to 600. And then I had mentioned that we have an Excel document that kind of helps us walk through these AUC MIC calculations. So I'd like to pull it up now for you all, just so you can see it. And if you don't have access to it and you'd like access to it, I'd be happy to email it to you. Okay, so this is what the Excel document looks like. Up here, you plug in your initial dose, which I know we gave her a loading dose of 2 grams, but for simplicity's sake, I'll go with our maintenance dose here. And then our dosing frequency was chosen to be every 12 hours. and then you input your infusion duration, so 1.5 grams, 1.5 hours. And here you put in your data that you get back from your peaks and troughs. So I just picked a random date and time to put in here, but this would be the date and time of your dose preceding the peak and trough. And let's say our patient's peak level came back at 46. I would put that in right here, and then put in the date and time that that peak was resulted. And then towards the bottom, we put in our trough level and then the date and time of the trough level. And then this will calculate what our predicted AUC would be. So here we have a predicted AUC of 548. It's therapeutic. It's within that range of 400 to 600. Would you guys like to make any changes to her therapy? Yeah, sure. Okay, what would you like to do? Sure, I think that's great. All right. So our chosen AUC goal is 400, so we can drop it to 1250, which I typed incorrectly. I apologize. And I think I just messed all of it up. Sorry, everyone. Oh, thank you. Okay, sorry about that. I had it right the first time. So our predicted AUC based on this chosen dose would be 458. Are you guys happy with that AUC? Awesome. So this is kind of a fun thing to play around with. Again, if you don't have access to it, I'd be happy to send it to everybody. But this is what we would use to calculate our AUC-MIC. And as I previously mentioned, that is a snapshot of what the patient looks like during that time of therapy. So if the patient's going to be on vancomycin for a long period of time, 2+ weeks, and their renal function and critical illness status is changing, you would need to do this multiple times. So to summarize what I discussed today, AUC-MIC monitoring is the preferred method to maximize therapeutic efficacy while minimizing nephrotoxicity for serious MRSA infections. Our goal AUC to MIC ratio is 400 to 600, and as I've shown in this presentation, that can be obtained with troughs less than 15. It's not necessary to monitor peaks and troughs when treating patients empirically, and as I showed with that mini MUE, most of our patients are actually on vancomycin for 1 dose or less than 1 day, so it would not be necessary to get peaks and troughs on those patients. And it's not necessary to get troughs when treating for short durations unless you're concerned with safety. And again, it's not necessary to get only troughs unless you're concerned with safety. And it would be really appropriate to get a trough in a patient with changing renal function, decreasing renal function, who is obese, just to make sure that you're kind of approximating a good AUC to MIC. And to conclude, the best utility is optimizing drug therapy rather than using vancomycin for everyone. Is everyone familiar with how to claim their CE credit? Great, okay, and I will put the code up here for you. And that concludes my continuing education presentation. I'd now like to open up the floor for questions and discussion. Cassie.
So, is the recommendation to only be checking for patients that have like a bacteremia? It's kind of like a lot of extra blood draw. What about
Definitely. Yeah, that's a really great question. So to repeat what Cassie had said, she asked, is the recommendation to only be checking peaks and troughs in patients with bacteremia, or can we apply this to pneumonia as well? So the guidelines are actually studied just for bacteremia, so that is the current recommendation. You can probably, there is some data, I referenced a study in there that used AUC-MIC monitoring for vancomycin in lower respiratory tract infections and did find some treatment success when targeting AUC to MIC in there. So primarily it is for bacteremia, but I think it would be reasonable to extrapolate this to other disease states as well. Does that answer your question? Okay, great. Anybody else?
Is there a place on that pharmacokinetic sheet if your MIC is not one?
That's a great question. So Megan asked if they're placed on the pharmacokinetic sheet if your MIC is not 1. I actually will check that right now. I don't see one. We're assuming 1 in most hospitals across the U.S. right now. If that changes, I'm sure Kyle would provide some updates or further information. And again, your outcomes would be worse the higher your MIC gets. So we would be probably veering away from vancomycin if our MICs creep above 1.
Yeah, so usually the MIC is going to be 1, and if it's 0.5, I think the guidelines say that you assume an MIC of 1. You don't change your ratio. You don't do the AUC divided by an MIC of 0.5. You just assume it's 1. And then usually if the MIC is 2, you're not going to do it.
Well, what about the technology we use here?
Sometimes, depending on the technology that your lab uses, they can actually either under or overshoot what the MIC is. So here, our machine sometimes overshoots. So even if the MIC shows a 2 here, the true MIC, if it was confirmed with like an E-test, would actually be 1. And then some hospitals, their machinery overshoots it. So that even if it said the MIC was 1, it might actually be 0.5. So.
Thank you.
So just use 1.
Yes, just use 1. Yeah. ID consult.
But you're saying, so even if the MIC says 2, it's probably overshot and we can still use it unless they're clinically not improving. Okay.
That's probably more a patient-specific issue rather than a true vulnerability.
So, Liz, you had mentioned that a lot of times we can target these AUC to MIC ratios with lower trough values. Was there any discussion in the guidelines about instead of a 15 to 20 trough, targeting the lower trough level?
There was not discussion of doing that. I think, as I mentioned in a couple of these slides, which I'll pull one up now for a visual effect. I think this is a really great slide to kind of depict what I'm talking about. Is there's just such a wide interpatient variance of AUC MIC correlated with a specific trough that it's really hard to use a set trough goal. As you can see here, if they talked about using lower troughs, we would be getting AUCs well below 400 if we were targeting 10 to 15. So I think it's just too much of a patient-specific factor to really make a blanket recommendation like that. And then the reason that the 15 to 20 was chosen because it almost guarantees that you're achieving a therapeutic AUC to MIC of greater than 400.
So for most patients, I would say studies show that 60% of patients can achieve an AUC above 400 without a trough above 15. And then you also think about what kind of mg per kg dose you're giving them. If you're giving them a pretty high mg per kg dose, you're going to get a higher peak, which we don't care about the peak, but that creates a higher AUC. So basically don't get bent out of shape if your trough's not 15. You probably shouldn't want it above 15 in most patients.
And that Excel sheet shows you based on what the calculation is, it shows you what trough you would estimate. So if you keep drawing trough levels every 2 days, it'll have like an estimated lower trough.
Yeah.
Look at the bottom right. So they get the AUC of 458. The predicted trough would be 5.7. They're usually not that low, but they're lower than 15.
Liz, can you remind everyone when we draw an appropriate peak, like what type of time an appropriate peak in case we get the question from the nurse?
Oh, yeah, definitely. So your peaks are drawn after your vancomycin infusion, so it's your highest concentration of therapy. So I don't know if, Kyle, you have a specific time you like, but like 30 minutes after finish of infusion, or do you draw it right after?
Do an hour after.
An hour. Okay. An hour after infusion ends.
So how should we write our vancomycin notes if they default to targeting a trough of 15?
That's a great question. So When writing vancomycin notes, I would recommend that you don't include trough goals any longer because the guidelines recommend not targeting a specific trough anymore. So I know the vancomycin notes populate to say targeting a trough of blank, and most of us will write in there 15 to 20 and then dose to that target. But I would recommend omitting that from your vancomycin notes, because if we get a trough back of 10 and your note says targeting 15 to 20, but you know in your head, oh, this is probably approximating an AUC, MIC of greater than 400, I'm not going to do anything, that can cause some conflicting information and confusion for providers.